Now, I would like to welcome all of you in this step 6 of ECG interpretation. So far, we have finished step 1, which is about the rate, step 2, rhythm analysis, step 3, axis determination, step 4, hypertrophy, and step 5, interventricular blocks. Now, this is the time to discuss and go through the step 6, which is about the infarction. Here in this step 6, we'll talk mainly about the ST segment, and we'll learn how to diagnose a myocardial infarction. Then we will have an exercise named ischemia versus infarction. Then we'll review that all that elevated is not myocardial infarction and ST depression. So first, ST segment elevation, and here we are going to learn ECG pattern of ischemia, injury, and infarction, and what and where to look for acute myocardial infarction. We'll go through the reciprocal changes associated with acute myocardial infarction, and then the importance of R wave progression in the chest leads. It's very important that when you want to diagnose myocardial infarction, you have to scan all the ECG paper. And the upper part of ECG paper, as we discussed earlier, shows the 12 lead ECG, and the bottom is the rhythm. And for myocardial infarction, we have to go through all the leads on the ECG paper. So these 12 leads are 3 limb leads, 1, 2, and 3 augmented leads, AVR, AVL, AVF, and 6 precardial or chest leads from V1 to V6. It's very important to notice that a normal 12 lead ECG does not mean that the patient is not having acute ischemia, injury, or infarction. So what it means? It means myocardial infarction can happen in presence of normal ECG. So when you are dealing a patient, treat the patient as a whole. Take the history, physical examination, laboratory assessment, and ECG analysis. So one way to diagnose an acute myocardial infarction to look at the elevation of the ST segment. ST segment is the area where the S wave ends and this T wave begins. This area between the end of the S wave and the beginning of the T wave is ST segment. Another very important point that when you are looking for the ST segment elevation, always try to find where is the J point. J is the junction where the S wave ends and ST segment start. The elevation of J point is extremely important in diagnosing myocardial infarction, because in case of myocardial infarction on the ECG, it's extremely important, and it's vital that J point must be elevated. ST segment can be elevated in many other conditions, but the J point is extremely characteristics of myocardial infarction. Then the shape of the ST segment can be concave upward, or this is concave upwards, that's a smiley face if you draw a circle around this complex, or convex upward, which shows the sad face. So if it's any face can be there, but the sad face is most significant with the acute myocardial infarction. There are many other possible shapes of ST segment elevation that may be seen with the acute myocardial infarction. So any shape can be seen where you will find the ST segment elevation that may be concave, convex, or extremely high or horizontal elevation. So any shape can be associated with the acute myocardial infarction. Then there are indicative of ECG changes as the time passes by. So in the first 6 hours, this phase is called hyperacute or acute injury. and on the ECG you will get ST segment elevation along with the peaked T wave. In the next 24 hours, from 6 hours to 24 hours, this phase is called acute or evolving. There is ST segment elevation and R wave becomes a bit smaller. Up to 72 hours, this phase is called recent myocardial infarction or resolving. Here, T waves start showing inversion, but ST segment is still elevated, but lesser than the acute phase, and Q wave may start appearing. From 72 hours till 6 weeks, this is called healing phase and undetermined length of the time. So here ST segment may become normal, no more ST segment elevation, but T wave inversion can be seen. And after 6 weeks, this is called old or healed or scarred infarction, and ST segment and T waves, they become normal, but Q wave persist for a longer period of time. Okay, when you want to diagnose a myocardial infarction, so you have to ask yourself two questions: what to look for and where to look for. So what to look for? So you are going to look for three things: the ischemia, injury, and infarction. And these are called the three I's of MI. Ischemia means lack of oxygenation, and on the ECG you will see ST segment depression or T wave inversion. Injury, when the ischemia gets prolonged, it causes the injury of the myocardium, and you will see ST segment elevation according to the area where the blood supply is compromised. And infarction happens when there is a death of the myocardial tissue, and this may be seen as a Q wave. In the clinical practice, we take the injury and infarct together, especially once we talk about the acute myocardial infarction. Right. When you get the T wave inversion or ST segment depression, we label it ischemia. But when we get the ST segment elevation, we label it injury. So ST segment elevation, how much is significant? If it's more than 2 mm in the chest leads and more than 1 mm in the limb leads, it's in favor of injury. Injury means something very acute event has happened. And in clinical practice, actually, we take the injury as fresh infarction. And when this ST segment elevation is present in 2 or more anatomically related or contiguous leads, then it becomes clinically significant. This is the area highlighted as ST segment elevation. And you see the J point is definitely elevated. So elevation of ST segment along with the J point is clinically important. And another thing which you have to look for are the presence of Q wave. If you get a significant Q wave, these are the real infarction. That means that area of the myocardium is dead. So the criteria for pathological Q waves includes the width more than 1 mm and height is more than 1/3 of the preceding R wave, and it should be present in 2 or more anatomically related leads. Clinically, these ST changes are called acute coronary syndrome, and we may divide into 3 categories: unstable angina, non-ST segment elevation myocardial infarction or NSTEMI, and ST segment elevation myocardial infarction, also known as STEMI. Now look at these two ECG complexes, and it shows the ischemia, T wave inversion and ST segment depression. So important point is that if you get these ECG changes in symptomatic patient, you have to do cardiac enzymes. If the cardiac markers along with the STT changes are normal, this is unstable angina. But if ST segment and T changes are present along with the raised cardiac markers, this is your non-ST segment elevation myocardial infarction or NSTEMI. So the presence of raised myocardium in association with the T wave changes and ST segment changes that are ST segment depression or T wave inversion, not the elevation. So if the T wave inversion or ST segment depression are present in presence of raised cardiac markers, this is called NSTEMI. If the cardiac markers are not normal, these are unstable angina. So look at this ECG. There are the deep T wave inversion in the chest leads, most significant from V2 till V6, and along with these ECG changes, if there are elevated cardiac markers, we label them non-ST segment elevation myocardial infarction. This is also myocardial infarction, but why to differentiate this one from STEMI? Because STEMI needs thrombolytic therapy and NSTEMI doesn't require this thrombolytic or fibrinolytic therapy. Now, the second question, if you want to see a myocardial infarction, where to look for? So how you are going to localize myocardial infarction? It's very significant to notice that there are two main coronary arteries supplying the heart, left coronary artery and right coronary artery. And according to the blockage of these two coronary arteries and their branches, you will see the ECG changes or ST segment elevation in case of myocardial infarction. So these color schematic areas are seen. If you see ST segment changes or ST segment elevation in lead 1, then you have to look at the AVL, then V5 and V6, because they are anatomically related areas, and these are labeled as a lateral wall of the left ventricle. Any ST segment elevation in this area is known as lateral wall myocardial infarction. If the ST segment elevation are seen in lead 2, 3 and AVF, then we will label as inferior wall myocardial infarction. If you see ST segment elevation in V1 and V2, we label septal myocardial infarction. In V3 and V4, anterior myocardial infarction. So these ST segment elevations can be in one group of leads or maybe more than one group of the leads. For example, it may be in the anterior as well as lateral, so we label anterolateral. Or in the septal and anterior, we label it anteroseptal. Or maybe in the inferior and lateral, infrolateral. So and so on. So let's talk first about the anterior wall myocardial infarction. If you want to see the anterior wall myocardial infarction, you have to look the ECG leads. These are the V3 and V4. If you get ST segment elevation in V3 and V4, this is your anterior wall myocardial infarction, and this is due to the blockage of the left coronary artery or left anterior descending artery or diagonal branch of the left anterior descending artery. You see, this is your left anterior coronary artery, and this continues as left anterior descending branch, and then there are circumflex and diagonal branches. If the left coronary artery is blocked somewhere, so it gives rise to anterior wall myocardial infarction and ST segment elevation on the ECG in lead V3 and V4. Look here, can you find ST segment elevation? Yes. These are ST segment elevation in V1, V2, V3, V4, V5, even AVL. So this is quite extensive. not only the anterior wall, which is V3 and V4, but also septum and the lateral. So we may call it extensive anterior myocardial infarction. If you want to see a lateral wall myocardial infarction, you have to look at the leads 1, AVL, V5 and V6. And this is due to the blockage of either circumflex artery or diagonal branch of the left anterior descending artery. If this area is blocked, you will get ST segment elevations in the lateral leads. Look at this one. Is there any ST segment elevations are seen? Yes. 1, AVL, even V2, V3, V4, V5 and V6. So lateral wall myocardial infarction is definitely there along with some anterior. So anterolateral wall myocardial infarction. As we are talking about the lateral wall myocardial infarction, just focus the leads which are related to the lateral wall. That are the lead 1, AVL, V5 and V6. If you see in this example, ST segment elevations are only seen in lead 1 and AVL. So 1 and AVL presents the high lateral wall, and V5 and V6 presents the low lateral wall, and V5 and V6 seems there is no ST segment elevation. So the only finding is the ST segment elevation in 1 and AVL, which presents the high lateral wall myocardial infarction. If you want to see the septal wall myocardial infarction or septal myocardial infarction, you have to look at the leads V1 and V2. These leads face septal area of the left ventricles, and it's due to the blockage of these septal branches. So look at ST segment elevation. It's seen in V1 and V2, which present the septum, and maybe V3 as well. So most striking is in the V1 and V2, which presents the septum. So this is your septal myocardial infarction. And if it's extending to V3 and V4, then we label it anteroseptal myocardial infarction. If you want to see the inferior wall myocardial infarction, you have to look at the ECG changes in the lead 2, 3 and AVF. And inferior wall myocardial infarction is due to the coronary arteries blockage, and these include the right coronary artery or posterior descending branch. So if any of these coronary arteries are blocked, you may get the findings in the inferior leads. Okay, now look at the lead 2, 3 and AVF. There is ST segment elevation. So this ST segment elevations in lead 2, 3 and AVF presents inferior wall myocardial infarction. Now it's very important, when you get the inferior wall myocardial infarction, you have to suspect 2 more myocardial infarction, and one of them is the right ventricular infarction, other is the posterior wall myocardial infarction. So as far as the right ventricular infarction is concerned, you have to look for the ST segment elevation on the right sided chest leads. That's V4 to V6 on the right side. You know, the normal 12 lead ECG shows us only the changes in the left ventricle. We can't see the changes on the right side of the heart. If you want to see the right ventricular infarction, you have to take all the leads from the left side of the chest and put them on the right side, and you will get the findings. So look at this ECG and you will appreciate ST segment elevation in 2, 3 and AVF, which is the inferior wall myocardial infarction. So whenever you see inferior wall myocardial infarction, it is important to look for 2 more myocardial infarctions. These are the right ventricular infarction and posterior wall myocardial infarction. For right ventricular infarction, you have to record the right sided leads. Okay, V4, V5, V6, or at least V4 right. sided, and you will see here ST segment elevation, and this confirms your diagnosis. So this is inferior MI along with the right ventricular infarction, because the blood supply is shared by these two areas. So again, if you get inferior valve myocardial infarction, you have to rule out one more MI, that's the posterior valve myocardial infarction, and usually in conjunction with the inferior or lateral valve myocardial infarction due to the blockage of right coronary artery or left circumflex artery. If you want to see a posterior valve myocardial infarction, which is not seen on routine 12-lead ECG, you have to record the ECG by putting the electrodes on the back of the chest. Okay, so you will put 3 electrodes at the tip, near the tip of the scapula, that is the V7, V8 and V9. And if you want to record the right side of the heart, then you put on the right side V7, V8, V9, R stands for the right side, and you will see the electrical events or ST changes happening on the posterior valve myocardial infarction. Sometimes we don't do, in fact, most of the times we don't do these posterior lead recording because we don't want to disturb the patient. So what we do, we may use a mirror image test. That is, if you place a mirror in front of the V1 and V2 in front of this ECG, the V1 here R wave will become Q, and ST segment depression will become the ST segment elevation. Or more simply, you can just take the ECG and invert it and then see. So this will become the R wave. R wave will become the Q wave, and ST segment depression will appear as ST segment elevation. So again, the most important thing is look at the lead, inferior leads 2, 3 and AVF. There is ST segment elevation. So this is inferior valve myocardial infarction, and if you see inferior valve myocardial infarction, you have to look for 2 more myocardial infarction. As I said, one is the right ventricular infarction, another is the posterior valve myocardial infarction. So just to see the posterior MI in presence of inferior MI, look at the lead V1 and V2. If you get R wave in V1 and V2 along with ST segment depression, so this is the posterior valve myocardial infarction indirect evidence. If you invert this ECG, this will become the ST segment elevation, and it confirms your diagnosis. So where to look for? You have to look for the blockage of the 2 coronary arteries, and you can localize the area of the myocardial infarction. For the septal myocardial infarction, look at the ST segment elevations in V1 and V2. In anterior valve myocardial infarction, you will see the ST segment elevation in V3 and V4. Lateral valve myocardial infarction, look at the ST segment elevations in 1 AVL, V5 and V6. If the right coronary artery is blocked, you will get 3 more types of myocardial infarction. Inferior valve myocardial infarction, you will see the ST elevations in lead 2, 3 and AVF. For right ventricular infarction, you will see the ST segment elevation on the right sided chest leads, especially V4 right. And if you want to see the posterior valve myocardial infarction, you will see the R wave in V1 and with ST segment depression. So you will get the findings that are the ST segment elevation in one group of lead or combination of 2 or more groups. Now, another important concept in the myocardial identification is the reciprocal changes. So just take this area, infarcted area, and put a camera in front of this one. So the front of this infarcted area, you will get the ST segment elevation, and the back of this area, you will get the ST segment depression. So just opposite. So that will be your reciprocal change. So if you get ST segment elevation in lead 2, 3 and AVF, you may get ST segment depressions in 1 AVL and chest leads. That these will be your reciprocal changes. And on the other hand, if you get ST segment elevation in 1 AVL or chest leads, you may get reciprocal changes in the lead 2, 3 and AVF. The reciprocal changes are not necessary to presume that the patient is suffering from myocardial infarction, but once they are present, they give the strong confirmation that myocardial infarction is there. And not all acute myocardial infarction results in reciprocal changes, but once they are present, they are extremely significant. Look at this ECG. First, you have to identify, is there any ST segment elevation? So just scan the ECG and you will find in the inferior leads, lead 2, lead 3 and lead AVF. This is inferior wall myocardial infarction. And now look, scan the other leads and you will get ST segment depression in 1 and AVL. So these are your reciprocal changes. So inferior MI with reciprocal changes. Look at this ECG. Can you appreciate ST segment elevation? Yes, in the chest leads V1 till V5. So this is your anterior wall or anteroseptal myocardial infarction. And now try to find ST segment depression anywhere else. Yes, ST segment depression in 2, 3 and AVF. So these are the reciprocal changes. Here it's very important concept that if you get ST segment depression in presence of ST segment elevation in other leads, these will be called reciprocal changes. So ST segment elevation along with ST segment depressions. So these are your reciprocal changes. And this area is the anteroseptal myocardial infarction. But if you get only ST segment depressions on ECG, then these are not the reciprocal changes. These will be your ischemic areas, ischemia. Now we'll talk about the importance of R wave progression. So what happens if you look at the chest leads and focus on the R wave is smaller in V1, and as it keeps on moving towards V2, V3, V4, V5 and V6, it keeps on increasing the size. So this is the normal progression. Okay, look at this ECG for comparison. V1 and V2. V1 here in these two ECG, if you see the V2, V3, it's V4, V5 and V6. If you look at this ECG, there is a very nice progression. That's normal progression in the first ECG. But if you look at the second ECG, there is a poor progression. R wave remains the same in especially in the first 4 leads. So this is somewhat poor progression, and there can be few causes for poor R wave progression. One is the anteroseptal myocardial infarction, left ventricular hypertrophy, bundle branch block may be a normal findings, obesity and chronic obstructive airway disease. Look at this ECG and try to focus on the R wave progression from V1, very small notch, but V2 nothing, V3, V4, V5, V6, you got here some R wave, but you see this is a poor R wave progression and there is ST segment elevation. So this is acute anteroseptal myocardial infarction and with poor R wave progression. Look at this ECG. these are the wide Codus complexes. So this is your left bundle branch block, V1 and V6. If you look, V1 wide and negative, and V6 is broad with the notch. And you see there are ST segment elevations as well. And ST segment elevation may be normal finding, but if you focus on the R wave progression, V1, V2, V3, V4, so it's a poor R wave progression. So poor R wave progression can be a part of left bundle branch block as well. So ST segment elevation is extremely important in your clinical practice. When ST segment is elevated more than 1 mm into anatomically related limb leads or 2 or more mm in the anatomically related chest leads, this is your indication for thrombolytic therapy, as well as the posterior wall myocardial infarction and left bundle branch block, or presumably new onset left bundle branch block. All these are indications for thrombolytic therapy. On the other hand, if there is ST segment depression or raised cardiac markers, this is not the indication for thrombolytic therapy. So in summary, ST segment elevation is presumptive evidence of acute myocardial infarction. So you have to scan all the leads for ST segment elevation or depression, inverted T waves and Q waves, and find the location of the pathology. For example, in the left ventricle, and then identify the occluded coronary artery. So finally, there is important message. ST segment elevation is not only affiliated with myocardial infarction. There are other conditions that may also cause ST segment elevation, and we'll discuss these causes shortly. Now, this is the time to go through a small exercise, and this is about the ischemia versus infarction. So I'm going to show you few ECGs, and you have to answer 2 questions: what to look for and where to look for. What to look for means you have to look ST segment elevation, at least in 2 anatomically related leads, and ST segment depression or T wave inversion in anatomically related 2 leads, and you may also find the Q waves. And where to look for in 2 or more anatomically related leads. So why it's important? Because if you get a finding in lead 1 only, this may or may not be clinically significant. But if you get in 2 anatomically contiguous leads, like for example 1 and AVL, then this is really important. So look at this ECG. This is lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5 and V6. And in the bottom 2 rhythm strip, the first rhythm strip is V1 and the second is lead 2. But we will focus the upper part of this ECG, and we will focus on the ST segment and T wave inversions and Q waves. So the first question, what to look for? So first thing you have to look for is the ST segment elevation. Any ST segment elevation, scan all the chest leads. No ST segment elevation. Any ST segment depression, yes. 1, AVL, then the chest leads V2, V3, V4, and lateral leads also V5 and V6. So ST segment depression or T wave inversion signifies ischemia. And which part? It's anterolateral. Lateral and anterior. So anterolateral ischemia. Look at this ECG. Is there any ST segment elevation? Yes. 2, 3, AVF. Okay. Now, any ST segment depression? Yes, in the lead V2, V3, V4, even V5. So this is inferior wall myocardial infarction. 1 and AVL also ST segment depression. Inferior wall myocardial infarction with reciprocal changes. So this is not, these ST segment depressions are not ischemia. Okay. So main pathology is here inferior valve myocardial infarction. Look at this ECG. Is there any ST segment elevation? Yes. Lead 2, 3, AVF, and also V5 and V6. So this is actually infralateral myocardial infarction. Now the next step is look for any ST changes. Additional ST changes, yes, in 1 and AVL there is ST depression. Okay, and these are the reciprocal changes. But here important thing is look at the lead 1, V1 and V2. There are R waves, more than 3 mm, significant R waves. So these R wave along with the ST segment depression is suspicious. So this is your posterior valve myocardial infarction. Infralateral MI with posterior extension. So I mean 3 areas are affected, quite extensive myocardial infarction. Look at this ECG. Is there any ST segment elevations? No. Any ST segment depression or T wave inversions? Yes, in 1 AVL and V3, V4, V5 also, and V6 as well. So this is your ischemia, and which leads anterolateral ischemia. Look at this ECG. Is there any ST segment elevation? Yes. Anterior leads V3, V4, V2, V3, V4, and lateral leads as well, 1 and AVL. Again, this is ischemia. Which area? Anterolateral. So this is anterolateral ischemia. Look at this ECG. Is there any ST segment elevation? Yes. V2, V3, V4, V5, and even 1 and AVL. So ST segment elevation is there, which is myocardial infarction. And which area? Anterolateral. And this ST segment depression in lead 3 and AVF are the reciprocal changes. So this is your anterolateral myocardial infarction. Look at this ECG. Is there any ST segment elevation? Yes, in V1, V2, V3, V4, even 1 and AVL as well. And remember that in limb leads you just need 1 mm elevation, and these are the reciprocal changes in the lead 3 and AVF. So this is your anterolateral myocardial infarction. Look at this ECG. Is there any ST segment elevation? So answer is yes. It's in the 2, 3 and AVF. So this is your inferior valve myocardial infarction and lateral as well. If you look at the V5 and V6. So infralateral myocardial infarction. And you see V3, V3, V2, V3 and AVL. These are the ST segment depression. These are reciprocal changes. But if you get the inferior MI, you have to try to find 2 more MIs, posterior and the right. Right ventricular infarction, you have to record an ECG. But for posterior MI, look at the same ECG and look at the V1. If you get R wave in V1 along with the ST segment depression, just invert your ECG. This will become ST segment elevation and this Q wave. So this is your inferior MI with posterior extension. Look at this ECG. Is there any ST segment elevation? So answer is yes. In 1 AVL, V2, V3, V4, V5 and V6. And this is your anterolateral myocardial infarction, and these lead 3 and AVF are the reciprocal changes. Look at this ECG and just focus the ST segment elevations. No ST segment elevation. No, look at the ST segment depression or abnormal T waves. No Now look at the Q waves. Yes, they are seen in lead 2 and 3 and AVF, and they're significant because they are more than 1/3 of the height of the R wave. In fact, they are bigger than the R wave in lead 3 and AVF, and these are significant. Okay, so this area is 2, 3 and AVF signifies the inferior wall. So this is your old MI, more than 6 weeks, months, years, nobody knows. So this is your inferior wall myocardial infarction, but old. So here, if you see ST segment elevation in V1 and V2 and V3 and V4, so this is your anteroseptal myocardial infarction, and these are the reciprocal changes in lead 3 and a little change in the AVF, but significant in lead 3. So this is your anteroseptal myocardial infarction. Look at this CCG and try to find, is there any ST segment elevation, any ST segment depression, any T wave inversions, any Q waves. These are not significant. No Q waves. So just relax. This is your normal ECG. So in step 6, so far we have finished how to diagnose myocardial infarction, and we have gone through an exercise where we try to differentiate the ischemia from the infarction. Now this is the time to see some other causes of ST segment elevation. That is, all that elevated is not myocardial infarction. And here we are going to learn non-myocardial infarction causes of ST segment elevation, and we'll try to differentiate ST segment elevation due to acute myocardial infarction from other causes. And we'll like to go through what changes in ST segment are seen in presence of left bundle branch block, or how to diagnose myocardial infarction in presence of left bundle branch block. Okay, so to diagnose myocardial infarction, it's very important to know the ST segment elevation. So what's the ST segment? It's the period between depolarization and repolarization. It means between the Kuras complex and the T waves, this gap where the S wave ends, junction point, and T wave begins. This is the ST segment. Okay. So most of the time in clinical practice, ST segment elevation is taken as myocardial infarction. Okay. So you can see different shapes. ST segment elevation is myocardial infarction. But remember, in many of the times, in different studies, even up to 35 to 50% of the times, sometimes other causes can be found, okay, as the reason of the ST segment elevation. And these includes electrolytes disturbances, left bundle branch block, early repolarization, ventricular hypertrophy, aneurysms, treatment like pericardiocentesis, injury. That's the most common cause, acute myocardial infarction. Then the cardiac trauma, contusion, Osborn wave of hypothermia, and non-occlusive vasospasm of Prinzmetal's angina. All these can cause the ST segment elevation. Then how to differentiate the causes of ST segment elevation between myocardial infarction and the other pathologies. So we'll go through these steps. Magnitude of elevation means how much elevations are needed to diagnose myocardial infarctions. The morphology and shapes, then the distribution of ST segment in various leads, then the width of the Kuras complexes, then the Kuras voltages, time factor, and some other features as well as per the history and physical examination and lab findings. As we have discussed in the previous section, any ST segment elevation of 2 mm or more in the chest leads and 1 mm or more in the limb leads is acute myocardial infarction most of the time. But if you get ST segment elevation less than 2 mm in the chest leads and less than 1 mm in the limb leads, that may be due to the non-acute myocardial infarction causes. Okay. Then the shape, morphology. If you get a convex shape of ST segment elevation or straight ST segment elevation, here is a convex shape, and if you draw a circle around this complex, you will get a sad face, which tells us that most probably this is myocardial infarction. But if you get a concave shape, that may be not acute myocardial infarction. Look at this ECG strip and focus the ST segment. These are elevated, but shape is concave upwards. So concave means if you draw a line from the P wave till the height of the R wave, and you will get some area below this imaginary line in case of concave ST segment elevation. So also you also note that there are very tall T waves and some notch is seen just immediately after the Curious complex at the J point. So this notching or slurring of the J point in presence of a concave shape ST segment elevation and tall T wave is a feature of benign early repolarization, and this may be a normal finding, especially in the young population. Look at this ECG. This patient presents with the atypical right-sided chest discomfort, and there are doubtful ST segment elevations if you see in lead V2, V3, V4, V5 and V6. So if you notice that there are tall T waves in some places, but there are notches also at the junction point, and there are no reciprocal changes. You notice there are no reciprocal changes. So this may be a feature of benign early repolarization, and this is not acute myocardial infarction. Another cause of ST segment elevation is Brugada's pattern, and when it's associated with the clinical feature, it's called Brugada's syndrome. And you will get right bundle branch block pattern plus ST segment elevation in the right-sided chest leads V1 or V2 and maybe V3 as well. So the most common variety is a type 1, which is covert type ST segment elevation, and you will get R, S, R, and but this ST segment elevation, the second R, is tent shaped. So Brugada's. So this is feature of Brugada's syndrome or Brugada's pattern. The other variety is a saddle type or type 2, where you will get the ST segment elevation of saddle shape. This is the ECG of a 21-year-old male, Asian descent, has presented to your emergency department following a brief episode of syncope. He feels fine now and wants to go home. If you look at the ST segments in this ECG, there is elevation in V1 and V2. And this is cover type tent shaped. And patient presents with syncope. So this is your Brugada syndrome type 1. If you look at this ECG, again there is ST segment elevation in V1 and V2, and if the patient presents with the syncope or other features, so this is your Brugada syndrome type 2, but the shape is saddle shaped. Another cause of ST segment elevation is the hypothermia, and you will see some very strange shape of the ST segment elevation at the J point. So this notch, elevated notch or ST segment elevation is called Osborne wave, and it's a feature of hypothermia, especially if the temperature is quite low. If you look at this CCG, you will get these strange shape ST segment in lead. You see here lead V2, V3, V4, and also 2 and 3. So this is your Osborne waves, and this is a feature of hypothermia, especially the temperature is if it's less than 28 degrees centigrade and extended exposure to cold. Then the distribution also important. So in case of myocardial infarction, it is usually seen in the regional or territorial pattern in the anatomically contiguous leads. Okay, so we have already discussed, but let's review once more that if you see a changes 1 AVL, V5 and V6, this means this is lateral wall myocardial infarction. 2, 3 and AVF, inferior wall. V1, V2 septal. V3, V4 anterior. So usually these are the anatomically contiguous leads. If you see the changes in these territorial pattern, this is more significant, and it shows that patient has myocardial infarction. But if you see the ST segment elevation everywhere, then this is not the myocardial infarction. Okay, so diffuse ST segment elevation may be a feature of pericarditis. Look at this ECG and try to find the ST segment elevation. So you see it's there everywhere. Lead 1, 2, 3, AVL, AVL is not probably seen, AVF and all the chest leads, but AVR and V1 are negative. So in most of the leads, ST segment elevations are there. So this is your pericarditis, and so in pericarditis you will see ST segment elevation in all the leads except AVR, and also there is another feature you can see is the PR depression, which may be seen with the pericardial diseases, pericarditis, and this PR depression in pericarditis is called Sportic sign. Then the other causes of ST segment elevation may be related to the width of the Kurtz complex. So look at this ECG, and you see there are wide Kurtz complexes, and if you look at the V1, there is a negative deep, wide, negative, and V6 are positive and notch. So this is your left bundle branch block, and if you see there are ST segment elevation also. So ST segment elevations are a normal features in presence of left bundle branch block, right? No, myocardial infarction can be seen in presence of left bundle branch block. Okay, but most of the time it's difficult to diagnose. But if we have certain criteria like Sgarbosa's criteria, then it may become easy to identify STEMI in presence of left bundle branch block. So look at this ECG complexes. This is from lead V1 and V6. So this is a feature of left bundle branch block. So you see a negative S wave in V1 and positive R with a notch in V6. So if you see these complexes it has two parts. The one is negative, which is S wave, other is ST segment. Okay, so the R wave or S wave should be compared with the ST segment. So this Curos complex, whether positive or negative, if it's opposite to the ST segment, this is called discordant. And if you get discordant Curos complexes changes on the ECG, it's normal. So left bundle branch block is usually associated with the discordant changes. Discordant means Curos complex is opposite to the ST segment. You see here, the Curos complex is negative and ST segment is positive. They're just the opposite sides. But if you get Curos complexes and ST segment in the same direction, this is called concordant. So concordance in presence of left bundle branch block is always abnormal. So what it means, if you see the Curos complexes and ST segment in the same shape, in the same direction, so this is clinically significant. Look here, this is concordant or discordant. So some are negative, some are positive. So this is discordant. So this is discordant. But if you see the ST segment are elevated too much, so too much discordant is also abnormal. So if ST segment are elevated more than 5 mm, again this is clinically significant. So let's sum up, so it will make a bit easy. Any ST segment elevation of more than 1 mm and concordant with the Curos complexes, mean in the same direction of the Curos complexes, carries the maximum points, that is 5 points. But if you get the ST segment depression of more than 1 mm in the V1, V2 or V3 leads, this is again significant, 3 points. Normally you don't get the ST segment depression in the left bundle branch block, but if you get ST segment depression, then this is significant. And finally, if you get ST segment elevation more than 5 mm and to the opposite to the direction of the Curos complexes, this is 2 points. This is a normal finding if it's less than 5 mm ST elevation, but if it's more than 5 mm elevation and discordant, then 2 points. So if your total score is more than 3, its myocardial infarction is likely. If less than 3, MI is unlikely. Let's apply the Sgar-Boss's criteria on the ECG, but let's review once again. Let's review the Sgar-Boss's criteria again, and this Sgar-Boss's criteria tells us the ST segment elevation myocardial infarction in presence of left bundle branch block. So the first criteria is that Curos complexes, if they are in the same direction of the ST segment elevation, this carries the maximum 5 points. The other criteria is if you get ST segment depression in V1 and V2 and V3 in presence of left bundle branch block, this carries 3 marks. But if you get the ST segment elevation opposite to the direction of the Curos complexes, and if it's more than 5 mm, then again it's significant, carries 2 marks. Okay, look at this ECG. This patient presents with the chest discomfort, and on the ECG you got the findings of the left bundle branch block. If you see lead V1 and V6, this is the left bundle branch block. And we know that ST segment elevations are a normal finding in the associated with the left bundle branch block. Let's see the where are the ST segment elevations? In lead 2, lead 3 and lead AVF, so means inferior wall. If you look at the lead 2, it's in the same, this is R wave and ST segment are in the same direction, concordant. Now look at the 3 and AVF. In 3 it's discordant, but it's quite tall ST segment, quite high ST segment elevation. You see the J point is here, more than 5 mm. And if you look at the lead V2 and V3, there is ST segment depression, more than 1 mm. So all three criterias, Garbosa's criteria are met here on this ECG. So this was your myocardial infarction in presence of left bundle branch block. Again, look at this ECG. There is left bundle branch block, obviously seen. V1 is negative and V6 positive with the notch and wide. And you see where are the ST segment elevations. Yes, these are ST segment elevation in V2, V3, V4, V5 and V6. If you look at the V5 and V6, especially the V5, there are R wave and ST segment in the same direction. So this is concordant. This is clinically significant. And if you look at the lead V2, the ST segment elevation and crus complexes are in the opposite direction, but ST segment are elevated quite high, more than 5 mm. So this is your acute myocardial infarction in presence of left bundle branch block. Sometimes on the ECG, you get notches in the crus complexes in presence of left bundle branch block. So if these notches are seen, they are helpful in diagnosing acute myocardial infarction in presence of left bundle branch block. A notch in the upslope of the R wave in a leads 1 AVL or V6 can be seen, and this is called Chapman sign. If you see a Chapman sign, it's highly specific for acute myocardial infarction in presence of left bundle branch block. Okay, now ST segment elevation can be seen in presence of the right bundle branch block. Right bundle branch block means you will get the wide tall R wave or RSR pattern in lead V1. Unlike to the left bundle branch block, in a right bundle branch block, any ST segment elevation is significant and it's abnormal. On the other hand, if you see ST segment depression or T wave inversion in lead V1 and V2, it's normal. But if you see ST segment depression or T wave inversions or Q wave anywhere else other than V1 and V2, that's abnormal. Look at this ECG. There is right bundle branch block, tall R wave and wide in V1 and deep S wave in V6. This is your right bundle branch block, and you see the ST segment elevation in V2, V3 and even 1 and AVL. So this is right bundle branch block, and there is anterolateral myocardial infarction. Anterior is quite significant. If you look at this ECG, again in this ECG there is right bundle branch block, but there are significant Q waves in 2, 3 and AVF, especially in 3 and AVF. So these are significant Q waves. This presents the old inferior MI. So Q wave or T wave inversion anywhere in the ECG except V1 and V2 are always abnormal. So this is your old inferior wall MI in presence of right bundle branch block. So the Q waves and ST changes are not altered by the right bundle branch block. Then another cause of ST segment elevations are high voltages, like for example in left ventricular hypertrophy. If you see this ECGs, there are ST segment elevations, but these are concave shaped. And if the patient is asymptomatic and taking the beta blockers for hypertension for over the years, and the ECGs are seen in repeated occasions, and then this probably is the left ventricular hypertrophy with strain pattern. We have already discussed that the ST segment elevation, if it's concave, this may be some other cause, like in the previous ECG it was left ventricular hypertrophy, but in a case of acute myocardial infarction it's convex or flat. Then the time factor. The ST segment settles with the time, especially after 2 weeks. It settles within 2 weeks, but if persists after 2 weeks of acute myocardial infarction, then you suspect ventricular aneurysm. This is a 56-year-old who presents 3 weeks post myocardial infarction, and you see ST segment elevation is still there, V1 and V2. So what you are going to do, you will do the echocardiography and it will be confirmed. Sometimes the patient comes to you in emergency department again and again with recurrent ST segment elevations. Like this is the ECG of 53-year-old male with recurrent ST segment elevations. And this elevation settles with the nitroglycerins. So this is your Prinzmetal's angina, or also known as vasospastic angina or coronary spastic angina. This is due to the coronary artery spasm. This Prinzmetal angina is a variant angina, and I said it's due to the coronary vasospasm. ST segment elevation on the ECG is seen and it's resolved with the nitroglycerin. Cardiac enzymes stays normal. Then there are other causes like electrolyte disturbances, and one of the cause is the hyperkalemia. In hyperkalemia, you will also get the very bizarre ST segment elevations as the level of the potassium increases. And other findings are tented or pointed T waves. So ST segment elevations are also seen. So it's very important, if you see such bizarre shape of the aqueous complexes, to make sure that you are taking proper history and some other blood tests. If there is a history of recent trauma, recent surgery, and you will get ST segment elevation in V1 and AVR and V1, this may be a feature of pulmonary embolism. Sometimes you will get ST segment elevations and little wider aqueous complexes in presence of small notches. If you see, these are the spikes, small spikes. So this is your pacemakers spikes. So ST segment elevations can be a feature of the paced heart. So in this case, dual chamber pacing. Trauma can lead to the ST segment elevation, as this is a 16-year-old boy who was involved in motor vehicle crash, and you can see the ST segment elevations in the anterior and lateral leads. So this is anteroseptal. This ECG picture of anteroseptal myocardial infarction, and this is due to the cardiac contusion. Here you are not going to thrombolyze because it's a trauma history. The drugs, cocaine has the high affinity with the oxygen and reduces the myocardial oxygen and causes the ST segment elevations. So again, history is very important. Tricyclic antidepressant, by blocking the sodium channels, can cause the bizarre shaped wide course complexes and ST segment elevation. So keep in mind the tricyclic antidepressant toxicity. If you see ST segment elevation in suspicious age, like very young unconscious patients. So in conclusion, although the ST segment elevation is a feature, is a hallmark of acute myocardial infarction, but not all the ST elevations are due to STEMI. ECG remains a good diagnostic tool, but must be correlated with the clinical history and physical examination. Certain characteristics of ECG changes may aid in the correct diagnosis, like for example morphology of the Kuros complexes and ST segment, distribution, associated Kuros complexes, voltage factor, and other significant history. All these are important to reach a proper diagnosis. Okay, so we have finished so far the myocardial infarction, that is the ST segment elevation, and then we have gone through exercise, ischemia versus infarction, and then we reviewed some non-STEMI causes of ST segment elevation, and now this is the time to review ST segment depression. And here in this topic we'll learn what is ST segment depression, and we'll go through some common causes of ST segment depression as well as some uncommon causes of ST segment depression, especially Wallin syndrome, and we'll practice some ECG strips. Common causes of ST segment includes the myocardial ischemia, and this is the foremost commonest cause. Then the reciprocal changes as a part of acute myocardial infarction. Posterior wall myocardial infarction, you will get the ST segment depression in V1 and V2 along with the R wave. Digoxin effects, you will get downsloping ST segment depression. Left ventricular hypertrophy with strain pattern can present as ST segment depression, and left bundle branch block, you may get ST segment depressions as well. So look at this ECG. It's a 58-year-old with the heartburn. So it's a significant history. Age, you see the age and symptoms, heartburn, and you see ST segment depression in one AVL and chest leads. So this is definitely your myocardial ischemia, anterolateral myocardial ischemia. This is a 62-year-old with the chest pain, and you see the ST segment elevations are seen in V2, V3, and V4. So this is your inferior wall myocardial infarction, and you will also appreciate ST segment depression in one AVL and in the chest leads, especially V2, V3, and V4, even V5 also. So these are your reciprocal changes. So inferior MI with reciprocal changes. Look at this one. It's a 62 years old with the chest pain, and here you see again ST segment elevation in lead 2, 3, and AVF. So this is your inferior MI, and in lead even the lateral is also V5 and V6. So this is your infralateral myocardial infarction, and if you see there is in one and AVL, this is ST segment depression. These are reciprocal changes. But additionally, on the top of this one, you will see the R wave in V1 with ST segment depression. So this R wave and ST segment depression, this is a suspicious. So this is your posterior wall myocardial infarction in addition to the inferior and high lateral myocardial infarction. So if you want to confirm this one, you have to record the posterior chest leads. Okay, So this is the ECG of a patient who is asymptomatic, and previous also ECGs are also the same. And if you get this ECG, there are wide course complexes, and V1 and V6 looks like left bundle branch block, but there are ST segment depression in V5 and V6. Okay, and also 1 and AVL. So this is not the ischemia. This is a feature of left bundle branch block. This is a 62-year-old Antin. Okay, his previous ECGs also are somewhat similar. So if you see in this ECG, there are very tall Kurus complexes. In fact, this is left ventricular hypertrophy, but there are ST segment depression in the chest leads and also in other leads as well. So it means there is a lot of strain is on the heart. So this is your left ventricular hypertrophy with strain pattern. But if the patient is symptomatic, then obviously you have to rule out the acute coronary syndrome. This is the 62-year-old male with congestive cardiac failure. Okay, so this ECG, if you notice, just will focus on the ST segments. So there are ST segment depression, T wave inversions. Okay, in 1, 2, AVL, especially V4, V5, and V6, and there's a characteristic shape. This is gradually down sloping ST segment depression. Okay, and the patient is also known case of congestive cardiac failure. Maybe he's taking some medicine. So this is digitalis effect. So this is in your academic sign, reverse tick sign associated with the digoxins digitalis. Now look at this ECG. This patient comes to the emergency department with the chest pain. He's a 58-year-old male. So this is his ECG recorded while he was having chest pain at rest. So you see these ST segment depressions, T wave inversions in V1, V2, V3, V4 mostly, and AVL also. But these are the chest leads are V2, V3, and V4, and most tracking is in the V2 and V3. So this is your ischemia, looks like. So patient was given treatment and kept for some times. Cardiac enzymes were done and they were found to be normal. So what happened when the patient was normal? So it was planned that the patient is going to be sent home. But before discharge, one of the responsible house officers requested another ECG. So this house officers should get the reward to be a hero because he is going to save the life of a person. So when the patient was asymptomatic, this ECG was recorded, and you see the very deep joint T wave inversion in lead V2, V3, and V4, and even extending to V5 and V6, 1 and AVL, but most significant in the V2, V3, V4. So this was your Wallin syndrome. This is the ECG manifestation of critical proximal left anterior descending coronary artery stenosis in patients with unstable angina. Right. So you see how critical is that. If you send this patient home, the chances that patient might turn up as broad dead or maybe die at home. So, or maybe with some more extensive myocardial infarction. So that house officer is a real hero. So this patient was taken to the angiography, and successful opening of the left anterior descending artery. Lesion was done after PTCA and stenting. You can see this is a blockage and it was opened. So it's very important that before sending the patient home, take an ECG. Okay, if the patient comes with the unstable angina. Now, look at another ECG. It's a 48-year man, alcoholic, intoxicated with the right-sided chest pain. Again, if you look at the ST segments, there are deep joint inverted T waves in the chest leads, and also in some other, actually quite widespread in the inferior leads as well, but most significant are here in the chest leads. So what will be your differential diagnosis? So there may be many causes. The most common cause is the non-Q wave myocardial infarction, atypical hypertrophic cardiomyopathy, subarachnoid hemorrhage because of raised intracranial pressure, severe right ventricular hypertrophy, and pulmonary embolism, high catecholamine states, for example, cocaine use, pheochromocytoma, okay, stress-induced cardiomyopathy, which is called Takotsubo cardiomyopathy, and pacemakers syndromes can also produce the deep giant T wave inversions. Look at this patient. This patient brought to the emergency department in unconscious state, and ECG was recorded. And look at the deep T wave inversion in V2, V3, V4, and V6. And this patient actually is a known case, is diagnosed as subarachnoid hemorrhage. So central nervous diseases can also produce the ST segment changes. This patient is a professional athlete, and his ECG was recorded, okay, after completing the marathon, and you can see the deep T wave in V1, V2, V3, along with some elevation some places and very hypertrophic, very high voltages, QRS complexes. So this is athletic heart syndrome. This is also normal findings in athletes. Cardiomyopathy can also causes the deep giant T wave inversions, and here in this example, if you see, this is more in the V3, V4, V5, and V6, especially towards the anterior and apical side. So this is apical cardiomyopathy. So it's a 65-year-old female with history of sudden chest pain and dyspnea after learning that her husband had died. Troponin is slightly raised. Echo shows the akinetic left ventricular apex with preserved systolic function. Angiography even was done, it's normal coronaries. So, but deep giant T wave is also a feature of broken heart syndrome. Takotsubo's cardiomyopathy or stress-induced cardiomyopathy. So all these causes you have to keep in mind. So this is 52-year-old female with the heartburn. And if you look at this ECG, there is ST segment depression in one AVL and in the V3, V4, V5, and V6. So this looks like ischemia. Okay, so whenever you see a ST segment depression anywhere in the ECG, just take a moment to look at the AVR. Look at the AVR. There is ST segment elevation, right? So ST segment elevation in AVR in presence of ST segment depression elsewhere in the ECG is significant. We usually don't give too much focus to the AVR, and AVR gets no respect. So ST segment depression elsewhere, look into the lead AVR. ST segment elevation in AVR in presence of ST segment depression elsewhere else is left main coronary artery stenosis. So it's extremely dangerous, this left main coronary artery occlusion. So this is 60-year-old with the chest pain, and you see ST segment depression in one AVL, even the chest leads, but you look at the AVR, there is ST segment elevation. So here, this patient, probably you are not going to offer the thrombolytic therapy, but the important thing is you have to call the interventional cardiologist. The reason is that this type of ECGs where you will get ST segment depression, most of the leads, and ST segment elevation in the AVR, it's associated with the 70% mortality or even more, and because it's due to the blockage of the left main coronary artery. Medical therapy will not improve the outcome, including the thrombolytic therapy. It means no drug will work. So, but invasive therapy decreases the mortality up to 40%, and that's the primary coronary intervention, and time to PCI is the only predictive of the survival. So take home message, in case of ST segment depression is there, in symptomatic patient with ST segment depression elsewhere, look at the AVR. ST segment elevation in AVR is equal to left main coronary artery stenosis, and call the interventional cardiologist urgently. And thank you very much. Now we'll proceed to the step 7 of the ECG interpretation.